Yeah, that's me. So you're a part. Okay.
All right. Hello, everybody. I'm Ann Smith-Tate. I am the president and CEO of the Shawnee Chamber of Commerce and Economic Development Council. And thank you all so much for joining us today for our annual Over the Back Fence event. I don't know about you, but during this time of COVID, I have been spending a lot of time and have a lot of appreciation for my own neighbors that are over my back fence. And our partnership and friendship with Kansas City, Kansas Chamber is no different. I'm of course a little disappointed that we're not doing this in person, because this is always one of my favorite lunches every year. It's so fun to see our members from both of our chambers gather and connect, and to see you know, our partners come together. So I'm sorry that we weren't able to get together in person, but I'm really thankful that we have the technology and the opportunity to bring to you today a partner of both of ours with the University of Kansas health system. So you know, we here at the Chamber are continuing to work hard for our members. We have continued to find ways to connect and advocate for our businesses and for our community. So on this side of the fence, things are pretty busy. How are they over there on your side of the fence, Daniel?
Hey, Ann, glad to be here with you again today. Again, it would be nice to be in person, but I'm so proud of the way that we've been able to leverage technology to get this done. We're busy here in KCK. We've not let a stay-at-home order or phase 1, 2, or 3 slow us down. Of course, we've seen our businesses take dips just like everyone else. But you know, I've never been more proud of our community, our entire metro community and business community. I mean, what a resilient community we have, and I'm just so proud of the way that we've rallied around one another and kept this thing going. It's important that we continue to do so. And then again, I do want to stress, you know, on behalf of the KCK Chamber Board of Directors and staff, how appreciative we are of this partnership. And of course, we don't get to do this work without the kind and gracious support of all of our partners. I do want to take a moment to introduce our sponsor for this luncheon today, a longtime friend and partner and 2-time Chamber Board Chair of the KCK Chamber, Mr. Craig Gaffney, Regional President of Country Club Bank, and new KCK Chamber Board Member, Jay Kimbrough, Senior Vice President. Gentlemen, thank you so much for your support.
Can you hear me, Daniel?
Yes, sir. We all can.
All right. I had to unmute myself. So good morning, everyone. Thanks, Ann and Daniel, for the opportunity to share sponsorship of today's Shawnee and KCK Chamber Over the Fence webinar with University of Kansas Health System. Ann, I echo your sentiments. I truly wish we all could be together in person at Lake Ladera as we traditionally do our Over the Fence event, but no, that's not possible right now. And appreciate Ann and Daniel and their staff's efforts for putting together today's webinar. As Daniel mentioned, I'm Craig Gaffney, and as our Country Club Bank Northwest Regional President, I've had the opportunity to see the great impact that both the KCK and Shawnee Chambers have had in supporting the business communities in Wyandotte and Johnson counties for the now over 16 years that I've been at Country Club Bank, and in particular at this most challenging time. Ann and Daniel, I know you and your respective board of directors will keep up the great work. As Daniel mentioned, I'm joined this morning by my associate senior vice president, Jay Kimbrough, who works with me on the commercial loan side in our Northwest region, and is a KCK Chamber board member, again, as Daniel mentioned, and as Ann mentioned, the Shawnee Economic Development Council member. You know, it's fitting that as we share today's sponsorship with the University of Kansas Health System, as I've had the privilege and opportunity over the last many years to get to know and work with KU Health System President and CEO Bob Page, Senior Vice President Brenda Dykstra, my longtime good friend, Director and Staff Assistant to Bob Page, and also a Kansas State Representative, Kathy Wolf-Moore, among many others in the health system. I've also had the privilege of working with KU Health System leadership as a banking partner for KU Midwest Ambulatory Surgery Center in Western Shawnee for many years. And myself and Country Club Bank were proud to support KU Health System by recently financing the expansion of a second KU Midwest ASC location on the Indian Creek campus in South Overland Park. Never in our lifetimes has public health and the financial health of our country been so inextricably linked. We're here to learn more about the prospects for a vaccine and therapeutic treatment protocols for COVID-19. Federal Reserve Chair Jerome Powell would tell you that economic recovery depends upon it. As COVID-19 spread and regional shutdowns were mandated, the federal government, in a cooperative effort between the Department of Treasury, the Federal Reserve Bank, and the SBA, devised a program to treat the ailing small business community by means of the Paycheck Protection Program, or PPP. 5,500 banks across the country delivered fiscal medicine to small businesses in order to keep them viable. Country Club Bank is proud to have been the fourth largest provider of PPP loans in the Kansas City metropolitan area. Over the span of 5 weeks, we originated over 1,300 loans totaling $215 million. That's a year's worth of production for our commercial loan team. Half of those were under 50,000, and perhaps some of you on the line today on this call would have been the recipient of those. As we await another dose of fiscal relief prescribed by Congress, we eagerly anticipate word of the breakthrough in treating the pandemic. We look forward to Amanda Gartner, Dr. Dana Hawkinson, and Chris Wilson's roundtable discussions on COVID-19, as clearly the University of Kansas Health System has taken the lead in the region, along with the research at the University of Kansas Medical Center, to battle and win the war against this pandemic. These are unparalleled times for all of us, and it's reassuring to have KU Health System and KU Medical Center physicians and medical research experts to tackle all the health challenges we face, be that COVID-19, cancer, heart disease, diabetes, and many others. So I hope all of you will continue to stay safe and healthy. God bless you all. Now back to you, Daniel. Thanks to you and Ann again.
Thank you, Craig and Jay, and I'm glad you mentioned your participation in the PPP. I cannot stress enough how important it was for you all to step up for our community. But then again, that's not uncommon for your bank. So thank you very much, Craig and Jay, for all your hard work in supporting our small businesses. At this point, I'd like to turn it back over to you, Ann.
All right. And I echo that. Really, Jay serves on our EDC advisory board. Craig has always been a great friend of Shawnee and our Shawnee businesses. And so these are why these partnerships all throughout all the years are so important, especially at this time. I do want to remind everybody that is listening that if you have questions, please utilize the chat function or the Q&A function. And at the end, Daniel and I will work to try and make sure that all of the questions are answered that we have time for. So please go ahead and make sure that you utilize that. I first want to start off by introducing our panel for today. Amanda Gardner is the Nurse and Director of Quality and Safety, Management and Infection Prevention and Control at the University of Kansas Health System. Amanda's clinical interests include reducing preventable patient harm events and is focused on understanding the role of human factors on patient safety events and identifying interventions that change behavior to improve patient outcomes. She has presented at numerous national and regional conferences on healthcare quality, safety, and process improvement, among other topics. She is currently leading multiple interdisciplinary teams in their work to ensure safety of patients, physicians, and employees during the novel coronavirus pandemic. We're also joined by Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control. Dr. Hawkinson leads a team in evaluating and managing infection exposures to staff and patients and developing infection prevention protocols. In addition to providing inpatient care, he holds weekly clinic to follow patients with HIV or who are receiving outpatient IV antibiotics. Dr. Hawkinson's clinical research focuses on respiratory virus infection and tick-borne illnesses. His research was integral to the discovery of bourbon virus, a suspected tick-borne pathogen. He is now helping develop a vaccine and a diagnostic test for this virus. And finally, we are joined by Chris Wilson, Vice President of System Integration and Innovation. He focuses on health system integration, digital innovation, and population health management. Chris is leading numerous efforts to coordinate the health system support of the community during COVID and is working to support the KU Lawrence campus in its response to the pandemic. Additionally, he is also the executive director of Centris Health, a physician-led, clinically integrated network comprised of 1,600 employed and independent physicians in the KC area. Thank you all. I know you are so busy, and we really appreciate your time and your dedication to the public health of Kansas City. And I will let you guys take it away. And then again, just a reminder, please put your questions in the Q&A or the chat function at the bottom, and we will take those at the end. Thank you.
All right, great, thank you. I would like to thank the Chambers for having us here. We will try to answer the questions to our best of our ability and keep you up to date with the most recent research and knowledge about COVID-19. So as a start, where have we been? You know, SARS-CoV-2 or COVID-19 is the disease, was first recognized in China, in Wuhan City in China. In late December 2019, it was identified as a new cause of pneumonia and severe illness. The virus itself shares some similarity to the original SARS, which was diagnosed in 2002. It has since kind of burned out. We haven't seen any more cases since 2003. The virus was thought to come from bats and thought to be circulating in bats for decades prior to making the jump to the human species, which is best estimated at probably November or December 2019. Since that time, the infection, which is mostly characterized by pneumonia, the original symptoms were cough, shortness of breath, and fever. Since that time, we've certainly gotten more knowledge about the clinical experience. It started in China and since moved around the world. We understand from the best of our reported knowledge that it probably came to the United States, both on the East Coast and West Coast, around late January to early mid-February. Probably on the West Coast from the Asian countries, especially China, and probably from the East Coast from travelers from Europe. Since that time, we have noticed that it has gone throughout the nation. We have had some areas that are harder hit and more devastated by the morbidity and mortality that this has caused. Currently, in our area, we do have less cases every day on a rolling 7-day or 14-day average than we did, say, back in late July, but we are still having about 400 cases per day in the metro area, which is still a large number. At this point in time, we still have a lack of testing capacity. Ultimately, we would like everybody to have access to testing, efficient testing where you can get results in a few hours and know that that result is true. But right now, for various reasons, there is a lack of testing capacity. We'd like everybody to get a test every day if possible to really try to vet out how prevalent and how far spread in the community is the disease. There is only one approved treatment for this, and that is the antiviral remdesivir. I think there are other antivirals on the way. We also have other treatment modalities that we are using. Currently, some of them are in study phase, and some are old drugs repurposed for treating COVID-19. The other drugs include dexamethasone, which is a steroid, convalescent plasma, which is a blood product from recovered patients, and anticoagulation. We know that blood clotting is a severe complication of this disease. More importantly, there are other single antibody solutions, not as convalescent plasma, but say monoclonal antibodies that we are looking at using at preventing disease after exposure and also treating disease if you do have the infection and you do have symptoms as well. But those are in phase 2 and 3 trials right now. In addition, moving forward, as it was touched on to really get the economy back to where it was, you know, vaccination is going to be an important part of that. So vaccines, there are at least 12 that look promising that are in phase 2-3 trials right now. We know that the Russia has an approved vaccine that has not really been vetted or studied appropriately. And China also has a phase 3 study going with the vaccine. But here in the United States, we do have quite a few vaccine trials undergoing. And right here at the health system, led by Mario Castro, we are currently enrolling people for a vaccine trial as well. So we are working on that. We are working nationally and internationally and doing our part to really try and stem the tide of this infection. And I would just like to say that I do love the Thompson family and working with Country Club Bank as much as possible. So with that current state of the virus and treatment and vaccination, I'll turn over to Amanda Gardner and let her do some statements as well.
Hi, as mentioned, I'm the Director of Quality and Safety and Infection Prevention and Control here at the health system. We have been working in our inpatient and outpatient population since early March to ensure that we can respond to the growing number of folks that are impacted by this virus. So every morning we have been meeting with an interdisciplinary team, anywhere from our EVS staff to our supply chain, our physicians, nursing, respiratory therapists, lab partners, to ensure that we are continually ready for the influx of patients that might come with this, this virus. I work closely with Dr. Hawkinson and also with Chris to support some of our community partnerships, as Chris will probably speak to his work with KU Lawrence campus. So that's a little bit of what we're doing here, or what my role has been, ensuring that our staff and all of our employees feel safe taking care of these folks. And also we've been impacted as the community spread, have had several of our employees impacted by the virus themselves. I don't have anything else specifically to mention, so I'll hand it over to Chris.
I would just like to say, you know, Amanda has been extremely important and the leader really in the health system and in the community on focusing on what we call non-pharmaceutical interventions to stop the spread of this disease. And that has been promotion of mask wearing, physical distancing, not meeting in large groups, hand washing, all of those infection prevention techniques that we talk about every day. Amanda has been the leader in expressing those to the health system, to our employees, to our patients, and to the community at large. And with that, we'll let Chris speak and go from there.
Great, thanks Dr. Hawkinson and Amanda. Really happy to be here today. Thank you to both chambers and also thank you to Country Club Bank. I've enjoyed serving with Mark Thompson on the KC Chamber board over the last couple of years. Really appreciate the partnership there. The first thing I'd say is that, you know, traditionally our health system has treated patients, right? And now with this novel virus and a pandemic, we've been asked more and more to work with organizations. So we're kind of treating this different kind of patient now, which is an organization that's trying to understand how it needs to manage through a pandemic like we're seeing right now. What we've done is basically culminated a lot of the work that our experts like Dr. Hawkinson and Amanda have researched and practiced for the last several years, but then in particular the last few months, and tried to compile that and provide a good advice to organizations that are trying to understand how to operate effectively and safely during our current environment. The themes that we talk about are the same themes that you've heard mentioned already. So certainly from an infection prevention standpoint, we very much emphasize masking, very much emphasize social distancing, hand hygiene. All those infection prevention practices are critical. They don't just need to exist in large groups. They don't just need to exist inside of healthcare settings. They need to exist everywhere that we are. The second area that we talk a lot about is testing. So quite a bit of activity in the testing space. A lot of businesses have questions about testing. Of course, there's different types of testing. Turnaround time is always a concern. I'd say the three main types of testing to be aware of is first the PCR testing, which is the traditional testing that you're probably most familiar with that nasal pharyngeal swab, the brain tickling swab that goes back to your behind your nose. That is a nucleic acid test that identifies whether there's nucleic acids being shed by the virus. Also, antigen testing is the second type of test that is identifying proteins from the virus. You're seeing an increased interest in antigen testing from a turnaround time standpoint. And then finally, antibody testing, that is testing to see whether you've had a prior infection or presence of the virus in your body. And that can be a confusing world for a lot of organizations that are trying to figure out how to get folks healthy, keep folks healthy, and isolate positives out of their organizations. The last area that I would really emphasize for the organizations that are on this phone is to work very closely with your county health departments. The county health departments are a fantastic resource. They're obviously strained during this time, but they are providing you the right guidance that you should follow. in particular around areas such as isolation and quarantine, and when to test and when not to test. We get a lot of questions about, can I basically test to come back to work? Those are really tricky topics, and generally we will defer to your county health department's guidance on what their opinions are on when to test and how to test, primarily because we're trying to A, stop the spread, and B, manage what is typically a short supply for our testing resources right now. So with that, I think those are just opening comments. So I imagine we're ready to open up for questions.
Thank you. And I should say that, Chris has been working tirelessly for 6 months now without any sleep to work with all of our community relationships and partners. If you do have relationships with us, to really find the best practice for your business and to really get that moving and keep it moving in a safe way.
Sorry, it's still muted. That was great. I mean, I have a lot of questions. We've got some questions coming in. I am curious. Well, here, let me start going through these on and Daniel and I kind of go back and forth on this. So what are the requirements to enroll in the clinical trial?
Yeah, so the requirements are, and I don't remember the website off the top of my head, but you can probably get it by Googling University of Kansas Health System or kumc.edu and Frontiers, and there is a hotline. The requirements are that it is somebody who we expect is going to be exposed in the community. Dr. Castro, who is one of our pulmonologists who leads the test here at the health system, and the website will be put up here, had stated, we want people who may have exposure to the virus. So if you are being very vigilant about quarantining at home, about staying at home, not going out and getting exposed, that is maybe not the population we want, because this study is to look to see if you are exposed, what happens if you've had the virus. The other requirements will be there on the website, and if you call the hotline, but that is going to be one of the major requirements, is that the people who are doing the right things and staying home and being vigilant about wearing masks and things of that nature may not be the best candidates for this vaccine trial, because we are looking for people who could have potential exposure.
Okay.
Looks like I'm up. Thanks again for all the information. This question is around HCQ. What is the University of Kansas Health System's position on HCQ?
Yeah, so I'll take
Dana.
that. So HCQ is the common abbreviation for hydroxychloroquine. Hydroxychloroquine, was initially came out as this is the drug to save everything, to save everybody. It should be noted that the initial trials were done in the lab. So they are basically using Vero cells, which are not even human respiratory epithelial cells, but more like monkey kidney cells. So they're not even the type of cells that the virus would infect normally. That showed possible antiviral activity. It should be noted that a lot of compounds, when done in the lab in the cell culture, may show antiviral activity. That was added on to by a group of French researchers who said, I've had 100% cure rate with using this. After we get into those studies and really understand them, and then other studies are performed which are validated more, it really found out that hydroxychloroquine in combination with azithromycin or alone did not lead to any reduced mortality, any reduced hospitalization, or any reduced complications. In fact, what it did was actually increase your risk of complications, and that specifically includes heart complications. In addition to that, they have looked at people who are using hydroxychloroquine for what it's FDA approved for, such as rheumatoid arthritis and lupus. And those people had no protection, even though they had been on hydroxychloroquine a long time. They had no protection from getting infected or complications from infection. Overall, hydroxychloroquine is not recommended. We have stopped using it at the health system for quite some time now, and in fact, it can be dangerous. So that is the bottom line, is that it does not provide any benefit to using it against COVID-19.
Thank you. Yeah, there's certainly been a lot of information out there in the media, and it's sometimes hard to know what is true and what is just fiction. At what point does herd immunity start to take place before a vaccine is ready? And is that actually realistic that we could achieve that?
Amanda?
You can take it down.
Okay. So herd immunity is a concept of if you have enough people in the community, i.e. a herd, that you can protect the people who are vulnerable to infection. Historically, herd immunity hasn't been reached unless you reach 85 to 90 to 95% of the people. Because if you think about it, even if 50% of the people have been infected and are immune, there is still 50% of the population which can be infected and can get ill. So with that in mind, some of the estimates for this particular disease, COVID-19, some people have gone down to 70 to 75%. You know, I think we are still looking at 80 to 90% if herd immunity works. Because we understand the devastation this virus can cause, how easily it infects people, and the mass amount of people that may seek medical attention. Even if 80 to 85% of the people who get the disease don't get very ill, if you have large numbers, that 15% that does get ill is still going to be a large number. In addition, we don't know exactly what kind of immunity you get after infection with SARS-CoV-2. Do you have immunity? Will you, if you get infected again, will you have any symptoms at all? Will you have worse symptoms? We think you do, and certainly from our best animal model, which shows that once you're reinfected within 8 or 10 weeks or 12 weeks, you have reduced amount of virus that you're producing and you don't get as ill. So we are hoping that you do have some evidence of immunity. And if you do come into contact with the virus again, at least for the short term, say 3 months, you will be okay and have reduced or no symptoms, but we don't know that for sure. And so that's the difficult part with herd immunity as well. And specifically with COVID-19, we don't know how much immunity an individual will have. We don't know how long that herd immunity or that immunity will last. That is why vaccination moving forward is going to be so important. On the questions of vaccination, is it going to mean you're going to need a vaccine every 3 months, every 6 months, every year like it is for influenza? Or even will you need maybe 1 or 2 or 3 different kinds of vaccine? And those are questions that we hope to answer as well.
Next question. And I think what they're meaning to say is updates. As a metro, why are we not getting daily current hospitalization, ICU, and ventilators updates?
Yeah.
So I can
Yeah,
share
absolutely.
what we provide. So every day we are providing that information. We report that out internally. We also report it out, Dana reports it out every morning on the media briefings. And we also are required to enter that information into the telehealth teletracking system that goes to both our state and federal government. So those are things that we do here at our hospital, and it is expected that every hospital shares that information.
I might also add, it's, unfortunately, data sharing has gotten political at this time. We wish it hadn't. We are all for sharing of this kind of information to help inform the community. Kansas City is in a bit of a tricky spot because you also deal with 2 states. And so we've had to work with both state hospital associations to make sure that they can get the information that they need, and then allow those organizations to help identify the reporting that needs to be required for the Kansas City Metro.
And I would like to add too that our CMO, Steve Stites, very early on got in touch with all of the CMOs around the community. Most all of them have been good. We continue to meet on a weekly basis sometimes, also in addition with David Wild, one of our VPs, who helps keep track of all that. So we do have communication with each other. And the CMOs overall in the community have been very good about providing that information. It's just not under our auspices, again, to provide other health systems or other hospitals information. But we have had a collaboration with other hospitals throughout the community. And I think we are all pretty happy with how it's been. And there's been a fairly free exchange of information with that.
I'll put a quick plug in for Dr. Hawkinson, who gets on a media briefing every morning at 8 a.m. in the same room and actually sits in where Amanda's sitting right now, and shares those numbers for our organization each morning with the community if you're interested.
Yeah, I see that come through quite a bit, that once you sign up for those, I get the notification daily that when it's occurring. So there's probably a way to put that in the chat function on how to get that signed up or sign up for that. So this next question is on challenge trials, which is obviously a very controversial topic, but could this be a method to streamline the most effective therapy vaccine to this pandemic? And I'm going to admit I don't totally understand what a challenge trial is. So maybe you could start there and answer the rest of the question.
Absolutely. So a challenge trial means we're going to give you this experimental vaccine candidate, and then we're going to actually challenge you with the infection. That means we're probably going to spray a mist into your nose to see with a certain amount of virus in it that we have calculated to see if you get disease. Because of these so many unknowns about COVID-19, a challenge trial would be very difficult. The same thing can be said for HIV. We're going to give you this experimental HIV vaccine, and then we're going to inject HIV, into your veins. Those challenge trials are very different because we know that, number one, what we don't know about COVID-19 and the risk that you could progress to severe disease and death. But the same thing for HIV. We know, although we do have good treatments, we know what can happen if you do get HIV. So those are challenge trials saying, we're going to give you this experimental vaccine, and then we're actually going to give you a challenge with the organism. So that is why it is very difficult with those types of things. For COVID-19, they aren't necessarily doing a challenge trial, but they want people who would be exposed otherwise out in the community, or the possibility of exposure out in the community. Same thing goes for the HIV vaccine trials. They aren't actively challenging anybody with the virus, but you have that potential to become exposed. Now, what I do know is that they are prepared to do these challenge trials for these vaccine candidates, but if they can do it with just natural exposure or assumed natural exposure, they certainly would prefer to do it that way. That is all part of this whole Operation Warp Speed to get vaccines going and to get a vaccine for this disease. But as of right now, they are not planning to do a challenge trial. Again, just because we don't know, number one, if the candidate works, and number two, we know the risk of what happens if you do get COVID-19.
Thank you. Next question. Saliva testing was just recently approved by the FDA as a method to do mass cost-effective testing at a relatively high effective reliability rate. Is this now a game changer in the testing arena?
I could probably take that one first. So I think so. So we do need to understand the differences, again, in the types of testing, but we would still recommend for the clinical setting, and in particular, if someone's symptomatic, that the nasal pharyngeal swab is the preferred method of testing. Still, it's kind of the gold standard there. But for doing broader testing initiatives, in particular, you think of large organizations, schools is obviously the one that I've had the most experience with. Colleges return to large organizations or gatherings or campuses. Saliva has presented itself as a very helpful option for collecting specimens that can then still be run on that same PCR test in the lab as the nasal pharyngeal swab. The benefits of saliva and some of the recent FDA approvals, like the one with the lab in Lenexa CRL that we've partnered with for doing our testing in Lawrence for the KU students and faculty and staff, is that it can be self-administered, which means you don't necessarily need a nurse with PPE administering doing the swab for each individual, like we would do in kind of more typical clinical setting or some of the other drive-through testing activities that have gone on. By doing that, we can reduce the labor force that is required to do testing. We can also reduce the PPE burn, and we're able to, depending on how you want to structure that type of testing, And the lab that you're working with, you could do it mail order. So there's a lot of activity with mail order salival testing right now. The way that we do it on the Lawrence campus right now for our MES testing events is to, we hand the individual a kit in their car. They pull into a parking lot, sit in their car for 5-10 minutes, complete the test, drop off their sample with us, and then they're on their way. And that's, we've had any wait lines or wait long lines with that approach so far. The other dynamic with saliva that is becoming more and more helpful for these screening types of testing is the pooling of samples. And this is a very old technique for infectious disease, but has some relevance now if we have limited testing capacity. But you could take 4 or 5 individual samples, put them into a single run on an analyzer in a lab. And if that run tests negative, then those samples are negative. If that run tests positive, then you still have enough of the specimen left to go back and test each of those samples individually, thereby avoiding the need to go back and collect another sample, but also getting your positives identified. Those two combinations of the self-administration and the pooling allow for basically scaling, doing more testing at scale. Some also exciting new developments in the last week or so out of a Yale protocol that was recently approved by the FDA to even kind of shorten the steps in the salival testing process that could help eliminate some of the expense that's required. Not all of it. There's still quite a bit of work that has to be done by a lab. This was a study that was done and developed in part with the NBA. So pretty interesting work there that the NBA partnered with the Yale School of Public Health to develop this. It's called Saliva Direct Protocol to be able to help advance the ability to do testing at scale. I think what we're seeing is sort of a transition with our testing, or maybe just another part of our testing portfolio, if you will. Again, we've had the clinical and diagnostic testing historically, and now we're looking at how do we do basically more testing with quicker turnaround times and quicker frequency. And that's an objective I think everyone wants to achieve. And so you're seeing a rapid development and advancement in the testing community to achieve that end.
So important, so important.
Mm-hmm.
So can you explain the differences between the different types of vaccines that are being developed and which ones are the leading candidates? And you touched on there's numerous that are entering, I think, phase 2, phase 3, and then of course the news out of Russia that they think they have one that is ready for mass production. Kind of where all that stands and what the differences are.
Yeah, so I think China has a inactivated vaccine, which is fairly new. So that is like the whole virus that is basically inactivated by heat or a chemical. That is a fairly new one. China has also, I think, gone into the phase 3 trials where they're giving it to all of their armed forces. And I believe that is an adenovirus vector, meaning we have this virus, which is not SARS-CoV-2, but is an adenovirus. Adenovirus is a common infection or a common virus in the human population. This one in particular, and most of them that use adenovirus are from a chimpanzee. And that is because that means that our body has never seen it. So number one, we can develop an immune response to that. And that adenovirus then will have a protein on it that is present on the SARS-CoV-2. And that is going to be the spike protein. So that is the little things that come off the virus that everybody has seen probably in the pictures. So those are the adenovirus vector vaccines. And again, that's going to create an immune response mostly toward the spike. The other vaccines are mRNA or DNA vaccines. And basically what those are is they are either put into another adenovirus vector. So again, a chimpanzee virus, but they have the genome or the sequence so that they can produce the spike protein. And that is what we are hoping to gain neutralizing antibodies for. It's important to note that also with the vaccines, we want to make sure we have good T-cell responses. That is a different part of our immune system that will help us clear the virus as well. So those are the adenovirus vector vaccines, and that is the ChAd-Ox or the Oxford study. And that is the part of the study that we at the health system are a part of, that Dr. Castro is the primary investigator on. The other types of vaccines, again, are the mRNA or DNA vaccines. A lot of times they are going to be the pieces of the genome that are going to be in these nanoparticles, or these very small particles that are injected, and then will hijack our own cells to start creating and pumping out, say, the spike protein, so that we now have an immune response to the spike protein. And that is going to be a majority of these vaccines. They are going to be directed against the spike protein itself. So these vaccines will not be able to cause COVID-19 because it's just a piece of the virus. It's thought to be the most immunogenic, meaning creating the most immunogenic part of the virus itself.
I'm not sure I totally. I was actually a public health major, ironically, but not a lot of it stuck. Can you
And it should be
provide?
noted that a lot of these are not new technologies. They have been around. They have been in trials with the original SARS vaccine, MERS vaccine, Ebola vaccine. So these are not necessarily new technologies for most of them. We have been using the adenovirus vector and studying that for quite some time, and so they've found to be safe as well.
Thank you. This next question, and again, as all of our members are grappling with not just reopening and staying in business. Now, once they've reopened and say someone tests positive, can you provide guidance on what that looks like after an employee tests positive? What are the steps that employers should be taking?
So one of the things that would be involved in that is through the county health department would be the contact tracing component of this. So identifying those folks who meet the close contact definition. It is important to acknowledge that different states and different counties might have a different definition of what a close contact is. For the state of Kansas, they've identified somebody who is within 6 feet for a duration of 10 minutes or longer. The CDC suggests 15 minutes or longer, but the state of Kansas has elected to stay within that 10 minutes, regardless of mask wearing. So if they are within that 6 feet, whether they have on a cloth mask or not, they're considered a close contact and would meet quarantine guidance or would have to be in quarantine for 14 days since that last exposure to that positive individual. If for some reason you actually came into contact with their droplets from either a cough or a sneeze, that person would also meet a close contact definition, regardless of the time that they were spending with that positive individual. So the close contacts would be in quarantine for 14 days. In the actual work environment, really the key piece there would be ensuring that there was good environmental disinfection performed, which in what we know about the virus is that any environmental disinfectant is probably effective against the coronavirus. We are less concerned about somebody touching a surface and then touching their mucous membranes as a source of transmission. It really tends to be related to that droplet impact or close contact with somebody who's infected. We've heard questions or concerns from do we have to shut down for a certain amount of time? Do we need to do mass disinfection using some special technology? And really, any good environmental disinfectant is satisfactory. I don't know if there's any other components I've missed there.
Yeah, in addition to Amanda being spot on as always, I would add there's the considerations for the individual that's the positive, making sure that they understand what they need to do, which is isolate at home. If they're asymptomatic, it's going to be 10 days, and in Kansas, at least 72 hours being symptom-free. If they're symptomatic, making sure they have the resources and the access to the healthcare and their physician in particular that they need to get as healthy as they can, as quickly as they can. I would also not underestimate what we've observed with organizations who are trying to manage through this, the administrative task of monitoring these types of quarantine timelines, isolation timelines, return to work, and especially for larger organizations where you could have multiple positives at once, all in different timelines. Your HR departments, your OC health departments, if they haven't already, would strongly recommend providing them a little more resource right now because they are going to be, again, if they haven't been already, inundated with requests and questions, and think about setting up hotlines because there is unfortunately, because of the way that our public health infrastructure works, there's a lot of difference by jurisdiction. Even among the medical community at times you can have disagreement on isolation and quarantine timelines. So would really support additional resources being provided to those individuals that have to help manage through monitoring timelines or answering questions of those people that have tested positive.
And that's why the masking is so vitally important for both parties who is ever together, whether it's somebody that's infected and other people that aren't infected. And we know this from the Morbidity and Mortality Weekly Report, which is a CDC publication that looked at hairdressers in Springfield, and 2 of which had COVID-19 out of 140 customers. When both the hairdresser and the client was wearing a mask, they did not find any apparent transfer of the virus or any infections to the client. So that is why mask wearing is so vitally important, in addition to the spacing as much as possible. But if you are unable to do that, physical distancing at the workplace, again, masking is so vitally important.
I have actually a question on the masks. So around our office, we wear masks when we're in our public areas, but we also have the face shields here. Are those as effective, or do you need to wear those in combination with the mask? Or it's, I will say, a little easier to have that face shield on than the mask, but I'm just was curious as to the how
Sure.
efficient that was or effective.
So what we know about face masks is that they provide what's called source control. So they keep your droplets to you and prevent them from dispersing to other folks. The face shields are really meant as eye protection. Eyes are another mucous membrane and a potential source of transmission. When you don't have that source control with a mask, whether it's a cloth mask or a gaiter or a bandana or a surgical mask, the face shield has not been demonstrated to be as effective as a source control mask. So if you're wearing the face shield, that's fantastic, but it's really meant as eye protection and not as source control.
Okay.
I know it's harder to communicate with one another when you've got a mask on, and we've struggled with that even within our healthcare facility prior to us going to everyone wearing a mask and everyone wearing eye protection whenever caring for patients.
Yeah. Well, and I'd
There's
wondered
the
about
new-
that with kids going back to school, if that would be easier for the kids, but
Yeah.
sounds like the mask.
It's not as, we don't have enough research to show it's as effective as a mask.
Okay.
Yep.
Can you discuss the changes you are seeing in the populations contacting the virus, the age, ethnic background, et cetera, kind of touching on that, hopefully getting back to school at some point in person, and what you're seeing on young children?
I'm actually gonna let Dana speak more to this. What I've seen just from our inpatient population, and I haven't paid as close attention to all of the outpatient testing that we're doing, but initially we were seeing an older population coming into the hospital and getting treatment. But I have seen patients ranging anywhere from early teens all the way up to, I think 99 was our oldest patient. But we're seeing it across all populations as we've started doing the testing in the at the KU Lawrence campus, obviously. We're seeing it more in the college age range, and we also know that children do get it.
Yeah.
So I don't know if you want to add.
Yeah, absolutely. And, I get the numbers from you, Amanda. So the demographics are exactly that. I think last week when we did our last demographic information so that we could give it to the public and the media update every morning, we had in the ICU, there was somebody from like 30 years old to 80 something years old. And on the floor, there was somebody from like 23 to 70 or 80 as well. So we are seeing that young population. As far as race or ethnicity, in the early parts, we did have obviously white or Caucasian. And then we had quite a high percentage of African-American or Black population as well, not only in the hospital, but in the ICU. Since I think July to now, or June till now, we have unfortunately seen a lot of Hispanic or Latino population. So we do see that it is changing. The demographics are changing, and they will probably continue to change as we move through this. I think in general, in our outpatient population, I do firmly believe that the rates of younger people, whether it's middle school or high school, has certainly increased through the summer with the opening up and the end of the school year, if you will. But also we know that the 20s to 40s, that group is out there and are probably less likely to be hospitalized. And that could certainly account for our reduced rates of hospitalization right now as well. We know deaths are continuing to increase though. We know that cases are really continuing to increase, but we also know that hospitalizations and deaths do lag behind new cases also.
I'd also add, I think over the next, say, 3 to 4 weeks, we are going to see a pretty significant increase in the younger population, say 25 or younger, with reopening the schools, both colleges and K through 12. I'm convinced there will be COVID in just about any education environment over the next couple of weeks. That's not to say that, it's probably not a more political topic right now on what to do about a school reopening, but I think just awareness that there will be COVID in educational forums. And that that phenomenon will influence the data that you see coming out about where the cases are landing. But I would also start to think about what we can do to help mitigate what we'll see there. So we want to contain those positives that happen in that age group so that they don't affect those populations that might be higher risk or older or immunocompromised. We want to make sure that those individuals that are younger that are positive aren't out in the community. As Dr. Hawkinson has talked about really well many times, that time period, that 1 to 2 day time period prior to your symptoms is oftentimes when you're most infectious, or at least the start of your most infectious period. So that asymptomatic or pre-symptomatic time frame is a critical time frame for us to make sure that we can remove individuals from the population.
Yeah, I would certainly agree with that. There are a couple publications now in the United States specifically that showed that, children probably didn't get it as much. Well, that was when we had the school shutdowns. And so that is really seemed to be affecting the children getting the disease early in the spring, but also overall our deaths. We have saved a lot of lives from the school shutdowns as well. So to Chris's point, we don't know where it's going to go from here, but certainly as you open up and have more people interacting with more people, although the children individually may be much lower risk of problems, who are they bringing it home to and who else is in their bubble that can spread to? So he made an excellent point.
Okay, I think we are close to being out of time. I know there are a few more questions out there, and we can try and get those maybe over to KU and get answers for individuals. I know there's just a lot of confusion. Everybody wants to get their business back up and running and get customers in their door, get their employees back in the office and our kids back in school. What is the one thing that we as business leaders in our community can be doing to help flatten this curve, to help get us back to our, I know we'll never be where we were before, but we all have a role as a leader in our own organization, in the community, in our schools, with our families. What is the 1 or 2 things that we can absolutely do today to make things better next week or next?
I think my advice would be the promotion of the good behaviors. I mean, we have to really take responsibility for our own behaviors and how can we prevent the spread of this disease. And so that would be what Dana and Chris and I have already mentioned, is the socially distancing, the wearing of masks, being very cognizant about if you're ill, don't go out in public, whether you have coronavirus or you have something else. Good hand hygiene and avoiding contact with your mucous membranes, it would be my recommendation. One caveat to testing, and I think it's something that comes up anytime an organization wants to do mass testing, is that a negative test shouldn't send you false hope that you don't have it or you can't get it, because you can encounter the disease out in the community so easily that just because you had a negative test run this morning doesn't mean that tomorrow you don't have symptoms and you need to be retested. And so that's something that, although we're doing mass testing in Lawrence now, that is really to try and find those asymptomatic positives. It doesn't mean that, oh, now we've got a whole bunch of folks who are negative and we can interact with one another. We really have to take responsibility, maintain social distancing, wear those masks, and really try to, the behaviors are going to be the big change, and it is going to be different than what it looked like last year.
Yeah, I would emphasize Amanda's point about negative tests. A negative test is not a get out of COVID free card. You really need to stay vigilant even if you have a negative test result. To answer the question, I would emphasize that the folks on this call are leaders in the business and the community in the KC Metro. I think you modeling good behavior, wearing your mask, keeping your distance, not only when you are in your formal business setting or in your meeting or in your organized activity, but when you're in the break room, when you are leaving work, when you are at home, when you are out with your friends. That's what we've seen over and over again, is that the organizations put a significant amount of effort into their formal practices in those traditional settings. But as soon as you leave that traditional setting, for whatever reason, individuals let their guard down. And so I would just encourage you to really start to model that behavior. And so it's not just within the confines of a typical space, it's how you act and behave when you're just carrying out your life every day.
Yeah. And I would like to echo both of those thoughts from Amanda and from Chris. It is not true that there is conflict of opinions and data about non-pharmaceutical interventions, including mask wearing and physical distancing. The overwhelming majority of the peer-reviewed articles and journals certainly promote and show favorable responses if people are doing those things, such as masking and physical distancing. And doing those things and continuing to endorse, and I know it's hard because it is a new practice, but if you continue to do those, you will keep your employees safe, you will keep yourself safe, and you'll keep your clients safe. So doing those things, in which the overwhelming majority of the reputable peer-reviewed journal articles, both on the population health in the countries, but also on the individual health in the communities and the businesses, that all promotes these non-pharmaceutical interventions. And if you can do that and change the culture in your own business, you can keep everybody as safe as possible, reduce the spread of the disease, reduce your risk of getting the disease, and hopefully we can kind of get through this until we get vaccination. But overall, I think it's going to be more healthy practices moving forward, especially now that we're moving into influenza season as well.
Certainly.
Thank you, doctors. Really appreciate your time and lending your expertise to our conversation today. I have a feeling we'll be inviting you back for a follow-up and update. I think it's time to adjourn our program. On behalf of the KCK Chamber, our board and staff, I want to thank you very much for your participation and thank everyone on the call. Ann?
Yes, thank you so much for your time. Thank you, Country Club Bank, for sponsoring this event. Daniel, it's always good to see you. And I do look forward to a time in which we can do this in person, but it does sound like it may be a while. But, you know, and again, to those listening, if there's other questions out there, get them to either Daniel and I, and we will work with you to get that information back to you. I know there's just a lot of questions and a lot of information out there to sort through for all of us. So really appreciate everybody's time today. Thank you so much, and stay healthy, be well, and we look forward to connecting again soon.
Take care, everyone.
Thank you.